Andrew Wolf here. In this video I'm going to talk about benign prostatic hyperplasia, and this is synonymous with the term that's called benign prostatic hypertrophy. They really mean the same thing. Hyperplasia is just a more accurate word because it refers to an increase in the normal number of cells leading to an increase in the organ. Okay, just to orient you to the space here, we have the bladder and we've got some urine inside of it so that you know where you are. And then over here we have the rectum, and then we have the prostate, which is a walnut sized gland tucked sort of in between here. And then running through the prostate we have the urethra. And then we also have, joining the urethra, sort of in the middle of the prostate. Then we have the right and the left ejaculatory duct coming together, and they of course go up to the seminal vesicles. Okay, so that just sort of orients us into space here. Now, the prostate is an interesting organ. It is very heterogeneous. In the anterior region here, this area here is primarily made up of smooth muscle and fibrous tissue. So in fact it's called the anterior fibrous region. Now there's an area right near the urethra coming out of the bladder and sort of wrapping around the urethra, and this is called the pre-prostatic sphincter. Now, interestingly enough, for males, the pre-prostatic sphincter and the anterior fibrous section of the prostate are very important parts of helping us remain continent. So that's their main function, in fact. Now, the rest of the organ is made up of, it's divided up into various regions. There's a central region that sort of surrounds the ejaculatory ducts, and there is a peripheral region, and these regions still have quite a bit of smooth muscle and fibrous tissue, but they also are interspersed with glandular acini. And inside these acini there's a sort of double layer of epithelium that includes both cuboidal epithelium and columnar epithelium that secrete the prostatic fluid that is the prostate's contribution to the ejaculate. So like I said, it's a very heterogeneous gland, and it is made up of nearly half, around 40 to 50% stromal tissue, which includes mostly smooth muscle and some fibrous tissue. And then the remainder would be glandular tissue. So about 50% glandular tissue. So that's the makeup of the gland. Okay, so let's talk a little bit about what goes wrong. It's interesting because we are the only mammal that develops symptomatic benign prostatic hyperplasia. Apparently it does happen that there is hyperplasia in dogs that's fairly similar, but dogs lack a thick capsule around, well, actually a thin capsule, but a fibrous capsule that surrounds the prostate like humans have. So their prostate is able to enlarge without transmitting pressure to the urethra. However, humans' prostate, when it enlarges inside this fibrous capsule, creates pressure on the urethra. So again, we're the only mammals that have this, but it's interesting because it actually happens quite frequently. Now, 30 to 40-year-old men, it's a relatively rare event, It only happens about 8% of the time in a male's 30, and then before 30 it's very, very rare. When we get up to the 50s to 60s, it ends up being about 50%. And then when you get up to 80, it's 80%. And the older you get, the more common it is. So probably, if you're lucky enough to live to the age of 100, you're probably close to 100% certain to have BPH. But that may be the least of your problems at that. So as far as the etiology of BPH, we know that old age is a factor. And there are various theories as to why this is, and it's really not clearly understood yet. One theory proposes that in old age, our prostate tissue has increased receptivity to growth factors. And I'm not sure why this is. The theory is that some of the stromal tissue in the prostate reverts back to sort of an embryonic state in which it becomes very susceptible to growth factor. Now, the other thing that we know that we've observed in men as they age is as we reach ages over 50 and 60, we start to have increased production of estrogen. So what does estrogen have to do with BPH? Well, estrogen seems to prime androgen receptors in the prostate. And that brings me to the other side of the equation. The other side of the equation is androgens. So in the prostate, our stromal tissue is stimulated by an androgen called DHT, or dihydrotestosterone. Now, this is about 5 to 10 times more potent than testosterone in activating androgen receptors in the prostate. Now, testosterone gets turned into DHT inside the prostate by a chemical called steroid 5-alpha reductase. Now, I bring this up not because 5-alpha reductase is part of the pathogenesis of the disease. However, it is now being used as a pathway for helping us block the disease, because we now use 5-alpha reductase inhibitors. The main one that I'm aware of is finasteride. And finasteride works not by decreasing the amount of testosterone, but by decreasing the amount of testosterone that gets turned into DHT. So that's the pathway by which finasteride works. Now, what does DHT do in the prostate? Well, DHT directs or stimulates androgen receptors, and these androgen receptors on stromal cells, so the smooth muscle cells, primarily will stimulate both stromal cells to grow, so we get growth of the number of smooth muscle cells, and they also stimulate the growth of acini cells, the cuboidal and columnar epithelium inside the acini. So this stimulates the growth of both. So we now the DHT, testosterone and DHT is not increased in people with BPH, but it's the receptors that are hyperactive. Now, again, one theory why the receptors are hyperactive has to do with estrogen. And beyond that, the answer is we really don't know. There probably are other pathways involved, but the theory is not clearly developed and it's not clearly understood. However, we know again that DHT is directing this hyperplasia because the androgen receptors are hyperactive in BPH. So by increasing the number of cells, we increase the size of the gland. It grows bigger and bigger. However, as it's growing bigger, it is pushing up against the fibrous capsule, and so as it grows, it increases pressure on the urethra. Okay, so what causes symptoms? Well, increased pressure on the urethra is one factor that causes symptoms. Okay, so factor one is simply increased pressure that's being transmitted by the hyperplasia, increased intraglandular pressure. Okay, now number two is with our smooth muscle hyperplasia, we develop increased smooth muscle tone. And particularly important is the smooth muscle tone at this prostatic sphincter. As well as the anterior fibromuscular zone. And this is, again, there's lots of smooth muscle there, and it normally helps us maintain continence. However, it's getting a little overactive here, so now it is causing urinary retention. Now, since I've been talking a little bit about medications that we use, it is this increase in smooth muscle tone that we use that becomes another area where we can treat the symptom of benign prostatic hyperplasia. And this treatment would be the alpha-1A blocker. Now, how does the alpha-1A blocker work? Well, it turns out that the sphincters in the pre-prostatic sphincter and the smooth muscles in the anterior fibromuscular zone, as well as the detrusor muscle in the bladder, all are stimulated to contract by the alpha-1 adrenergic receptors. So if we block the alpha-1 adrenergic receptor, we are going to cause these muscles to relax, and that will decrease urinary retention. Now, interestingly enough, I have known some urologists that actually prescribe a alpha-1A blocker to women. And why is that? There's no prostate, right? But they do have a detrusor muscle. So an alpha-1A blocker can actually help a woman with urinary retention because it may help to relax that detrusor sphincter. Now this would of course be an off-label use. So just to remind you what I'm talking about here, so these are alpha-1A blockers. The main ones that I'm aware of and that I've used are terazosin, which is, I believe the brand name is Flomax, and then prazosin. I don't remember the brand name for prazosin. But those are the alpha-1 blockers, and this is how they work. When the prostate increases in size, the prostate's sort of smushed in between organs. We've got the pelvis, right here in front of it, and then we have a thick muscular and fibrous diaphragm just underneath it. So as the prostate increases in size, it really doesn't have many places to go. And one of the places that it goes is it actually presses up against the bladder. And it actually can directly interfere with the detrusor sphincter. So number 3 would be interfere with detrusor sphincter. And that can also cause compression. Now, a fourth factor causing urinary retention in patients with BPH may be something totally unrelated, and that fourth factor is neuron degeneration. So, if a patient has peripheral vascular disease, they may have some existing neuropathy. And it is also possible that there are nerves that get compressed by the BPH. Whichever the cause, it is possible that we could have some degeneration of the nerves, and that can further exacerbate the urinary retention. Okay, so those are the main 4 causes of urinary retention with BPH. And I hope this video was helpful to you. If you have any questions, please ask them below in the comments, and if I'm able, I will answer them. And also, I will put up a couple of links to quickly subscribe to my channel if you'd like to, and for quick and easy access to the playlist on renal physiology and pathophysiology. Hope to see you in other videos. Thank you very much.